Okay.
Okay, thank you very much. So I'd like to ask Dr. Hind Elzein to start her first case presentation. Thank you, Dr. Hind.
Right, good afternoon, everyone. So I'm going to present the first case, which is about a 73-year-old gentleman with a biprosthetic aortic valve, which was done for aortic valve stenosis due to congenital bicuspid aortic valve. And he had also a Dacron graft to the proximal aorta. That was in 2012. He has a mild left ventricular systolic impairment, and that was by the echo scan, which was done 2 years prior to his admission. At that time, the valve was well functioning with no issue related to his valve and his ascending aortic graft. And he was actually on 3 yearly follow-up with the CT aortic root and proximal ascending aorta. And the latest scan was done about 2 years prior to his admission, and it showed some mild calcification in the circ and RCA, so there was no significant coronary artery disease. So he was admitted, he was admitted with 2 weeks history of shortness of breath and symptoms of orthopnea, paroxysmal nocturnal dyspnea with increasing leg swelling and reduced exercise tolerance. He also had 4 or 5 days of fever with sweats and cough productive of free sputum. Other background, just to mention, other significant background for this patient is hypertension and high body mass index and some arthritis and rheumatoid arthritis. He was on amlodipine for his hypertension on admission, was on aspirin, and he was on 40 milligram of furosemide, and he was on hydroxychloroquine for his arthritis and some ibuprofen like PRN and some salbutamol inhaler. He lives with his wife. He walks around using a stick, so he's relatively independent, and he's a non-smoker, drinks a little bit of alcohol. On clinical assessment on admission, he was apyrexial. His heart rate was, he was tachycardic, heart rate was 150 beats per minute. He was hemodynamically stable, blood pressure was within normal, maintained saturation 94% on room air. Examination of the heart revealed no audible murmurs with a normal heart sound. He showed some signs of failure. He was actually in failure with a raised JVP, bibasal crackles with slightly reduced breath sounds bibasally. He had a moderate leg edema up to thighs, and his weight was 123.5 kg in admission. So part of the workup was the ECG.
So if you can, when you go back one step, Hind, you can just go back one step.
Yes.
Go back one slide. Okay, so I'm just going to stop you there and just ask for some input here regarding the clinical presentation. Perhaps one of the panel members can comment on what their thoughts are at this stage before we go on to look at the ECG.
Can I come in there, please?
Yes, of course.
Right. So thank you very much. It's a very, very interesting conundrum. I think it kind of represents what we see on a regular basis in clinical working, and I think I'm grateful that you've highlighted it, because it actually shows up the dilemma that we are facing with these conditions. I refer to some of the stuff that I've already spoken about, which is around the pre-existing illnesses and the warning signs of where we're going. So this gentleman is, and I deliberately didn't speak about BMI earlier on, but BMI is also one of the factors recognized. So elderly male, elevated BMI, pre-existing cardiovascular condition, including heart failure. And perhaps in the whole of that, what he's missing is not being a diabetic, but who knows, he might be a maturity onset, diet controlled, hypoglycemic as well. The fact that he has developed this illness and what the giveaway is obviously the fever and the cough would suggest, which is over and above his baseline cardiac function, is suggesting that there is an additional agent here that is active, and that in the current climate is probably COVID or any other viral illness that might have decompensated him. The heart rate of 150 is suspicious, and I would be very keen to look at. Now, obviously, we've all seen the ECG, but my point electively was that, I would be suspecting that something else has happened. People in this situation don't go to 150 and remain stable without decompensating. So usually it's atrial fibrillation or a severe sepsis that's causing this. So high risk person with high comorbidity and likely to have a poorer outcome if he doesn't respond to early treatment.
Thank you very much, Professor. And just one, can somebody comment, perhaps Dr. Mohammed Badri, on where would you assess this patient in terms of, is this patient someone you would suspect to have COVID? Would you assess them in a COVID section of the hospital or non-COVID section?
I mean, initially, this patient has a background of cardiac disease, so he should be assessed in a COVID ward at least, because he's very suspicious of having shortness of breath or dyspnea. Although the background could be have gotten tachycardia with heart rate of 150, new onset arrhythmias or endocarditis. But still, I mean, suspicion of having a COVID there, and we should be very careful when screening these patients.
Thank you very much. So that would mean you wear appropriate personal protective equipment when you assess these patients. Be mindful of where you're assessing them in the A&E department. So Dr. Hind, could you please carry on with the presentation?
Should be very careful about doing when we are doing the echo for them.
Yeah, thank you. So if you'd like to show the ECG, and perhaps we can ask one of the other panel members, perhaps Dr. Yaqub, to comment on the ECG.
Yeah. So to start with, this is a 73 gentleman with background history of AVR, and now presented with acute decompensating heart failure with tachycardia and fever, although temperature is normal in the clinical examination. So obviously, coming to the ECG is clearly identified atrial fibrillation. There is some left bundle branch block, which is not uncommon in this type of patient as his age and background history of cardiac surgery. So the ECG is clearly showing atrial fibrillation, left bundle branch block, and some PPCs as well.
Thank you very much. Thank you very much, Dr. Musa. So please, can you carry on, Dr. Hind?
An old ECG, actually, just to compare. As we can see, he was a normal sinus rhythm, though it's really quite old ECG. Was just to show maybe just some T inversion in the lateral lead, but there's nothing exciting actually. Maybe just this is X-ray. As we can see, anyone would like to comment on it, or shall I just carry on, Dr. Ahmed?
Does anybody want to comment on the chest X-ray?
He got a cardiomegaly, the heart is very enlarged. He got a pulmonary congestion, which suggests pulmonary edema, but still on this background, still cannot exclude a COVID. But it looked like a very congested lungs with a very big heart. So this is a picture of heart failure to start with.
Can I just also jump in, please, if you don't mind, Ahmed?
Yes, of course.
So slight sort of difference of opinion would be it's a rotated AP X-ray. The mediastinal shift towards the left clearly suggests that the position of the patient is awkward, and also because this individual is 123 kilos, the exposure is critical because there will be a lot of soft tissue for the X-rays to get through. So I would have commented on saying this is a rotated X-ray, poorly positioned, underexposed. But having said that, those are the caveats. There is clearly evidence of bilateral infiltration. I'm not sure I would comment on the heart size just at this stage, but clearly knowing what we know, I wouldn't be surprised if the heart is enlarged. So very, very suspicious X-ray. The right costophrenic angle is not visible as clearly as I would like it to be. But if you look at the soft tissue shadowing over there, there is clearly the mammary tissue is enlarged and superimposed. And what you don't understand is whether there's fluid in that base or whether it's just soft tissue overlying it. So very markedly unusual and abnormal X-ray, but I would stop there.
Okay, Dr. Hind, if you'd like to carry on.
Right. So yes, as actually mentioned, this obviously an abnormal chest X-ray and shows diffuse pulmonary congestion, both lungs. The costophrenic angle is not very clear, but it might be there is very small amount of effusion. But the remarkable finding is the congestion in both lung fields. Blood tests were remarkable actually for a raised white cell count and neutrophil count and a low lymphocyte count. CRP was not particularly high actually, and his kidney function showed stage 3 chronic kidney disease with a creatinine of 115. Calcium, magnesium, and thyroid function test were normal, and lactate was normal. ALT was slightly high, probably secondary to congestion. So at this stage, the initial diagnosis for this patient was new atrial fibrillation with rapid ventricular rate and decompensated congestive heart failure and lower respiratory tract infection. He was actually initially treated as high suspicious for COVID, but his COVID screen was negative.
Okay, so if we could just go back one slide. So does anyone have any comments on that? Does anybody agree or disagree with that? So Dr. Said would like to.
So I ask this question to myself when I'm looking after COVID patients. And the question I ask is, what is the pre-test probability of them having COVID? And that is the reason I ask myself that question, is to get away from what we call COVID blinkered diagnoses. If you look at where we are now to where we were 4 weeks ago, majority of patients were COVID test positive. Where we are in the UK with the flattening of the curve, majority are now 90% negative. So you've got to remember your pre-test probability. This case, the clinical finding, one important thing, the cough with COVID is usually dry and non-productive. His cough is productive and green sputum. So you may have an overlying infection, lower respiratory area, and maybe a decompensated heart failure. You may have COVID, but the pre-test probability, you've got to put the time scale on that. Are we talking about the case right now, in which country, this country, then the pre-test probability is low, and I would predict he would be a low risk case. If you asked me 5 weeks ago, I would have said he was intermediate or high. So you've got to ask the question at the right time, because this is the issue currently of the rapid assessment units and other places, that if you just have 2 symptoms, shortness of breath and fever, then you'll be looking after COVID for the next 3-4 years.
Said, can I also make a comment around the test itself? I think one of the things that I don't know, I'm sure people are aware of this, the sensitivity and the specificity of a COVID test in the current day and age varies quite significantly depending on what you're using. And the Roche test that we use has probably about between a 65 to 70% sensitivity. So just be aware of and this is just for general audience consumption, is that a negative test may not be negative. And also in terms of the exposure, there is nothing that suggests that this person's exposure to COVID, wherever that might happen, is he a day 1 exposure? Is he a day 3 exposure? Is he a day 6 exposure? And the probability, again, the retrospective data that's coming out of the registries is suggesting that if you test too early, you might have a negative test, which then becomes positive, and the probability of positivity increases with days, right the way up to day 6 and day 7. So just be conscious of that we are dealing with an illness that is very new to us, and the impact of that on our normal ways of thinking is going to be variable. So I am looking at it from a slightly different angle. I mean, as Said is looking at it from the point of, what other possibility might explain his symptoms. I'm looking at it. I know what the other possibilities are, but could this person have COVID? I think the background tells us that he's at high risk of it.
Thank you, Dr.
Yes.
Nasreen. Yes, please.
I think even having the lymphopenia will raise the suspicion. Yes, you cannot tell, but being a high-risk patient, it's better to take the possibility of having COVID earlier on, so the prognosis will be worsened if we delay putting this possibility. So I will be very considerate about his lymphopenia and will take it as a part of COVID.
Thank you very much. So I think most people would say that they would test for this type of patient with this type of presentation. I think most people would say they would test for it up front. Would that be fair to say?
Yes.
Does anybody disagree with that?
I would say test and then retest. Okay,
great. And in terms of precautions, where would you manage this patient? In a side room, in an open ward? What would?
Ideally in a side room, and then with monitoring and do the basic treatments that we do and watch for the response. If he responds and the retest in 24 or 48 hours is negative, then we are on a winning track. If, however, he is continuing to deteriorate despite the treatment, then suspicion is high that he's hiding something.
Great, thanks very much. In some centers, sorry, Dr. Said, yes, please.
Yeah, so this is the risk now. Your pretest probability is intermediate or low. I wouldn't cohort him with other patients waiting for results, because the risk he then has is negative. Either he becomes positive because he's got true positive and the first test was wrong, or he then becomes inoculated with other patients who are truly positive who are waiting in the same area. So I agree with Shai, he should be isolated, a repeat test done, because his pretest problem for me is low, but he should be in a side room on his own, treated as COVID with all the PPE that you need, and retest maybe 4 or 5 days down the line. And then if that's still a negative, then he's a true negative. He can then come onto a normal ward. But I wouldn't put him with other people who are waiting for results or who are already positive. I wouldn't do that.
Okay, thanks very much.
Can I ask about the role of an early CT chest here that could help us in identifying whether the patient will be in a separate room or just in the ward? A CT chest.
Yes, that's a very good question. I don't think we're doing this at the moment. Certainly not in our centre. We don't do routine CTs, but certainly that is one possibility. But the other issue is that some of the changes you see on the CT may be similar to the changes that you'll see in heart failure. But yes, that certainly is a consideration.
Can I come in, please?
Yes, of course.
Sorry, I think the helpful sort of intervention in this individual is isolation and aggressive treatment of heart failure and AF upfront. That probably, and the response to that is probably a better discriminator than a CT, because if you've got heart failure or COVID, there are, as you suggest, overlapping features on the CT. So I don't think the CT will discriminate as easily as we would like it to. It's a radiation exposure, which perhaps is not that relevant in this context, but it still is an unnecessary radiation exposure. And it doesn't actually, I'm not aware of any data that helps you look at that CT and say, I'm going to change my management in any other way. So I think you'll still be sorting out the hypoxia, the heart rate, and the blood pressure, and the fluid output. Those are the things that you would want to, ideally isolation. As the Said's point is relevant, that these should not be in mix with other patients, et cetera, et cetera. However, in the circumstances that we practice medicine in this country, we have over the years done away with separate room hospitals. A majority of our wards are now shared wards. And that was for economy of scale rather than any clinical sensibility. And we are now regretting having moved from having single rooms to large shared wards.
Great, thanks very much. Dr. Hind, could you continue with your presentation? Thank you.
Okay, so indeed this patient was actually isolated in a separate room. because he was highly suspected for COVID. Even after his COVID screen was negative, he was still in a separate room. So if we come to the management for this patient, so the aspects of management, as Professor Junaid mentioned, the treatment of his heart failure, his atrial fibrillation or heart rate control, and of course, treating his acute infection and the assessment for long-term anticoagulation. So he was put on telemetry, started initially on bisoprolol oral. We will come later to the how he was managed from that point of view. He was started on the heart failure treatment, IV furosemide, initially 80 milligram twice a day. He was also started on oral potassium, as his potassium was in the lower limit of normal, and he was started also in IV furosemide that will lower his potassium further. Was put on fluid restriction to 1.5 liter per day, daily weight and daily renal function and intake output chart. And the plan was to repeat transthoracic echo once his heart rate is controlled, just to reassess his heart function and cardiac status. For his respiratory tract infection, initially was started on IV tazocine for a couple of days, and then he was switched to oral carmoxyclav. His CHAD-VAS qualifies him to be started on DOAC, and he was actually started on Apical 5 milligram twice a day.
Okay, if you just go back one, Dr. Hind. Okay, so anyone have any comments about that management plan, initial management plan for that patient? Yeah, Dr. Said.
It's unlike the she's hypokalemic or he's hypokalemic. So the standard case short-term measure is like he was already on a diuretic before when he came in. He's going to continue on a long-term diuretic. So I'd be looking at amiloride instead of Sandoke as a long-term, because he's going to be on diuretics long-term. You're going to only give the Sandoke maybe 3 days, and then you're going to leave them off and send them home and then find out they're still hypokalemic thereafter. So that's the only thing I would think of doing. And then the apixaban, I would obviously look at the creatinine clearance. You have to calculate that rather than the EGFR to work out the dose to give them, because he's got a CKD stage 3 already.
Okay, and Prof. Shahid Junaid?
I would, thank you very much. I think a very valid point. Sid, the other option might be things like eplerenone or spironolactone, which will be potassium sparing as well in the longer term. From the heart failure point of view, there is more prognostic gain from doing that rather than for amiloride. But anyway, you know, either or. I think I would have been a lot more aggressive in the AF management, i.e. IV metoprolol or amiodarone upfront if there is hemodynamic stability to allow to do that, because the quicker we get him back into sinus rhythm, the less or the shorter his illness is going to be, and the earlier we are able to get him out of hospital rather than put him into COVID exposure type sort of situation. And I wouldn't even hesitate considering DC cardioversion up front if I've got facility to do a TOE to make sure that he hasn't had AF for long enough to cause him to be having a intra-atrial thrombus. So for now, those would be my comments, and to try and get him out of hospital as quickly as I can.
Okay. Anybody else have any comments? Dr. Abu Saud? Yes.
Yes, Dr. Ahmed. Actually, I want to make a point here. I mean, in terms of potassium sparing diuretics, I would rather wait till we do the echo, and if his ejection fraction is lower than 35, then he's eligible for a prognostic benefit from starting eplerenone or any aldosterone antagonist, and this will help with his potassium level as well. In terms of atrial fibrillation, actually, I would rather prefer to unload the left ventricle and try to bring down the filling pressures by diuretics. Then I can reassess the atrial fibrillation later on. That because when filling pressures improve and when we unload the left ventricle, that might help with the rate control of atrial fibrillation. And I think at some point of time, if we do the echo and the left atrial size is very big, then at that point of time we might think of long-term rate control rather than rhythm control, which might be unsuccessful, or it might not be maintained if we revert to sinus rhythm.
Okay.
I've got a comment about
Yeah,
was
Dr. Badri.
front fluid meter before the echocardiogram or knowing the fluid balance. I think that I will wait for that. That will be maybe in plan B till I saw what is the echo findings, what is urine output, and what is fluid charge showing.
Okay, that's great. Professor Junaid.
Yeah. Can I come back on those 2 points, please? Absolutely, and I agree. I think if you turn the clock back by about 6 or 7 weeks, when we did not have, or sorry, even about months, when we did not have COVID to fight with, and we were looking at managing heart failure, acute decompensation in elderly people, and so on and so forth, I absolutely agree that that would have been my position as well. I think in the last 2 or 3 months, what we've learned is that the quicker we can turn these patients around and get them out from a risk environment, if they are stable going out, they tend to stay out and behave, less at risk than they would otherwise. I mean, Said alluded to earlier on, and my experience also is that we have high comorbid patients coming into hospital for acute exacerbations of their already established chronic illness. Then they stay in hospital for a longer period of time, acquiring other things that they didn't have when they came in, and then the outcome becomes bad. Now, from a COVID perspective, the background of this individual is a high-risk background. This individual is not going to do very well if he picks up COVID or already has COVID. So the quicker we can stabilize and get him out, the better it'll be. The point I omitted earlier on to mention, I think we probably are alluding to that indirectly, is an echo is critical, because the other thing that you want to find out is this patient has had a tissue aortic valve in place. We need to understand what the gradient of that valve is. Is there degenerative valve disease? Has he now got critical aortic stenosis that's causing a problem and his LV dysfunction? And that should also influence what other treatments we give him. If there is significant aortic stenosis, then high-dose diuretics or other medications are likely going to be detrimental. So early echo, early rhythm control, early intervention is probably the best way for this individual.
Dr. Yaqub.
Yeah. Thank you, Ahmed. Thank you, Hind, for nice case. So this just tells us how COVID era changed our understanding and our practice in when dealing with heart failure. And this again, it tells how central heart failure is in the COVID era. So this patient is typically AVR, who was stable, moving around despite his being 73 years. There was no mention about any risk of contact because just his wife is taking care of him. And he presented with very clear acute decompensating heart failure on background of AVR. So after we offload, then we need to ask ourselves one central question. What is the main drive of taking this patient to the hospital? I mean, what is the main cause of his decompensation? We can see that is having atrial fibrillation, which is new, with rapid ventricular response. COVID being negative or positive, I don't think is going to impact anything on his management. It's just important for epidemiological viewpoint and protecting staff. But for his case management, is not going to change much. So I would prefer, after just putting some IV furosemide, then I will look to tackle the atrial fibrillation. 150 heart beat per minute is fast in someone who is already have AVR and EF was 42 years ago. So I would go for risk control because this is new onset atrial fibrillation. And then depending on echo, we see where to go elsewhere.
Okay, thank you very much. Thank you. So we've got quite a lot of, you can see this is a real case and there's variation in practice. And there's some that are saying we need to tackle the rhythm, get the rhythm to sinus let's tackle the heart failure. So I think there's lots of ways you can tackle this particular case. Timing of echo, his heart rate is 150. Perhaps Dr. Abu Saud, maybe we can comment on the timing of echo in this sort of case.
Yes, Ahmed. Actually, I think at the moment, if we have to ask ourselves first before doing the echo, what are we looking at? If you are looking at assessment of LV systolic function, then I think this is not the right time to be looking at it, because with such high heart rate and the R2R variability, that might be very difficult to precisely assess the ejection fraction. I would say if the patient is not hemodynamically unstable and things, I would rather wait for some time till we unload the left ventricle and get some fluid off, then assess the ejection fraction when the heart rate goes down a bit.
So I guess what you're trying to say is that the assessment of the valve will be affected by the fluid status of the patient, and perhaps wait until their heart rate is better controlled and they're offloaded. Would everyone agree with that as a strategy?
Exactly. The preload affects the assessment of the heart function.
Okay, so Dr. Hind, could you continue your presentation?
Okay, so so this patient had a transthoracic echocardiogram, which was a targeted scan, the view of the COVID. As we know, as you can see, that there is no.
We'll just ask Dr. I'm just going to ask Dr. Abu Saud, as an echo specialist, if he can comment on this.
Yeah, I just want to say that this echo was not done immediately. It was done after the heart rate was controlled, maybe in about 4 days, following the start of the heart rate medication like bisoprolol, and he also was on digoxin. So I'll just leave the floor for you to comment. Okay.
Yeah. Thanks, Dr. Hind. So looking at this apical 4-chamber view, I understand that it probably was hard or technically difficult study because of the BMI of the patient. So many segments of the left ventricle can't be seen well, but I can say that RV is not dilated. The left ventricle, it looks for me like severe impairment of LV systolic function. I can't see the lateral wall clearly here, but I can say from the apex and septum that it looks global rather than regional variability. Maybe the basal septum is moving a little better than the rest of the ventricle, but I would say this is clearly severe impairment.
Okay. Anybody disagree with that? No? Okay, so if you can carry on to the next slide.
Okay, so yes, just I'll comment as we can see that unfortunately it was a really poor echo window, and this is just secondary to the body habitus of this patient. But obviously we can see the obvious the LV is really impaired. The RV appears to be contracting, but it might be dilated. If we go to the next slide. So as we can see here, shall I read that?
So we're going to ask, Dr. Saud, we've got some more views here.
From here in the 3-chamber view, I think there is some foreshortening of the apex. So it's but again, the infralateral wall looks to be severely hypokinetic or akinetic. The septum as well, at least till the mid-septum, is severely hypokinetic. The color on the LVOT, I think it's not clearly open, not fully open, but it doesn't show significant regurgitation, and I can see a little bit of mitral regurgitation coming in the view here.
Thank you very much. If you'd like to move on, Dr. Elzein.
Okay, so they were very quite limited views, actually. The whole study was about 10, maybe to 12 images, and I've chosen the best of them actually. But I would just comment on this. If we can see here, the aortic valve, it looks very thickened here and doesn't open really well. It could be due to the poor function. This is only single view for the short axis of the aorta. The only view that was done with this study is not really visualized, you can see. And any comments that you'd like to?
Yeah, I can't see the leaflets here very well. Yeah, but I think it's not opening well. Yeah, I think maybe some Doppler data can help to increase the suspicion of you know, malfunction of the valve.
Right. Okay. So yeah, I agree. It's not really clearly visualized. It's only this is the only view that I got from the scan of this patient. We can see the Doppler here. It might be more than 2. Again, there was no measurement as it was really quite limited to study, and the recommendation is not to do any measurement during the scan anyway.
Okay.
So that was the report of the cardiac physiologist. This scan was reported as severely impaired RV systolic function with global hypokinesia. Normal RV size was impaired RV systolic function and mild LA dilatation. The biprosthetic aortic valve reported a slightly thickened with a velocity of 2.8 meter per second and a maximum gradient of 44 with an average of 33 and a mean gradient of 24. And this is compared to the previous study done abnormal, or there is an increase in the Doppler gradient and velocity. There was no paravalvular and transvalvular leak, mild MR, and trivial TR. So these are the measurements which was done by the cardiac physiologist who done this scan.
You can just go to the next slide, please, Dr. Hind. So thank you very much. So I think, we included this case really to highlight that actually getting an echocardiogram in the COVID era can be very challenging, because there is, patients are, and scanners are at risk of, echocardiographers are at risk when they are scanning patients. And the British Society of Echocardiography gives some recommendations for how to perform a transthoracic echo during the COVID era. And I've just mentioned them here. I'm not going to go through every single one, but certainly one of the issues is that you should avoid ECG, use time loops, and do a focused scan, and to try to minimize the amount of time that you're spending with patients. And then take all your pictures and perform the measurements offline. Now, you can see that actually the quality of the echoes during this period may not be as good as they were prior to COVID, if the echocardiographers are following this particular advice. Does anyone have any comments about that, and whether they've seen that in their own clinical practice?
Can we comment on the echo itself, or yes?
Yeah. Yes. Yeah.
Yes. Yes, I agree with you that the limitations of the study and the situation that echo have been derived on. But could I comment on this hypokinesia that, or this global dysfunction that has been worsened than before? Could it be related to myocarditis affecting as a new pathophysiology affecting the patient, leading and even the, causing even further decrease of the flow across the valve, so the aortic valve? So could be new pathology to worsening of his cardiac function.
Professor Janejo?
Thank you very much. In defense of the BSc, can I just say that the guidelines were picked up or developed in the context of the COVID to try and answer the commonly asked questions in people who are not known to necessarily have cardiac disease, and they come in with symptoms that might suggest an acute cardiac event, i.e., does somebody has a left ventricular dysfunction? Is there a big vegetation sitting that is obvious, or does somebody have pericardial effusion? Those are the kind of simple, or right heart dilatation in acute breathless people with PEs, suspected PEs and stuff. That is the simplistic approach to why these guidelines were developed. The echocardiogram as a tool is far more complex and tremendously valuable in a lot of patients. And I think we just need to be careful not to allow the possibility of getting an infection override the value of a test when it is actually clinically necessary and would help in treatment. I go back to what I had said earlier on, which is, I think an echo, I agree with pure rate control, it doesn't make sense to look for left ventricular function. The couple of questions that you would want is, in a situation like this, is where is the fever coming from in a vulnerable patient? Have they got endocarditis? Is there a big vegetation? Have they got an effusion? What does the valve look like, if at all possible to judge? Although the pre-test probability, as Saeed was referring to, in somebody who has got a body mass index which is high and a weight of 120 kilograms and a heart rate of 150, that going to give you accurate information is small, but it gives you a feel for what the valve looks like. And I'm reasonably pleased with the comment that the aortic stenosis looks slightly worse than what it was before, but clearly the valve on visual assessment is not moving. Thankfully, there's no big vegetation. The ventricular assessment, in my opinion, I think we knew clinically the guy was in heart failure. So if there are regional wall motion abnormalities, he's in atrial fibrillation, he's got a bundle branch block. Are we surprised that that we're seeing these? Probably not. I think the value was excluding effusion, look at the valve and get a feel for what the valve looks like. If the valve is worse than compared to before, or there is a clinical big thing sitting on the valve, then you've got your diagnosis. At this point in time, I think this guy's got a combination of degenerative aortic valve disease with an arrhythmia in the context of an infective illness. We're still not sure, but we understand what that infective illness is.
Thanks very much. So Dr. Hind, if you can carry on, please.
This patient had a blood culture which showed no growth. Considered with a blood culture, which was negative. He did not have a troponin or bronchi, this patient. So, and I think the myocarditis was not considered in this patient, and there was no troponin actually requested for him. This is just a slide about the clinical course of this patient during admission.
If you can move on to the next slide, so I think that shows a nice summary of what the management was for this patient. If you go to the next slide, that's yes.
Right. So this table shows how this patient was managed from the heart failure point of view, starting from day one when his heart failure was treated. So on admission, as we know that he was on 40 milligram of oral furosemide and started the day on admission on 80 milligram IV furosemide, and that was continued for 2 days. And his initial weight was 123.5 with a creatinine of 115. After 2 days, he was switched to oral, and due to his creatinine, which started to increase by day 3, it was about 127. He was put on 120 milligram of furosemide orally. His weight was not actually responding very well. On the 3rd day, his weight was 123.2. He continued on 120 milligram of oral furosemide till for about 2 days, actually. On the 4th day, as we can see, his weight reduced to 122.5. So he started to lose weight and his creatinine has improved. So even below the baseline, actually. And he continued on that dose until on day 4, actually, he was started on candesartan. So the candesartan was started on day 4 after admission, and his amlodipine was stopped. Then he continued for a couple of days on this dose until day 6, and he was still losing weight. Actually, his creatinine was still improving. And then he had a single dose of metolazone. And he's, by that time, actually, I think in day 5, his furosemide was increased to 120/80. And on day 6, he was given single dose of metolazone on the base of that he was slowly responding, still having much feet and leg edema, though he was losing weight and his urine output was good. The next day, his furosemide was increased to 120 milligram twice a day. His weight was 119 with a creatinine of 136. I think it was started the same day when his kidney function showed this reading of creatinine. Then the next day, on day 8, actually, his creatinine started to creep up to 150, and his weight was still responding very well, actually. And the furosemide at that stage considered to, sorry, I'll just go to the previous one. I just forgot to mention on day 7, his spironolactone was started. He was started on 25 milligram of spironolactone. And the next day, we could see that his creatinine went up to 150. But his weight was responding very well, as we can see. So the event that happened prior to this creatinine, prior to the rising creatinine, starting the spironolactone, he was given a single dose of metolazone, and his candesartan was started actually like 3 days prior to that.
Dr. Hind, if you just go back a second. So I'd just like to invite anybody to comment on this sort of management regime. I think we forgot to mention that the patient was started on bisoprolol and was quickly up titrated to 10 milligrams within the first 2 days. That's the only thing we forgot to mention. But in terms of diuretics, IV versus oral, and responses in terms of the renal, according to the renal profile and the creatinine.
Yeah, can I comment on that?
Yeah.
Yeah. So thanks, Hind, again for this nice case. Obviously, this patient presented and admitted with acute decompensated heart failure. Obviously, he was on 40 milligram oral furosemide. Then obviously you need to shift to IV furosemide as done actually by treating this patient actually. Coming to the renal function in the setting of acute heart failure, then we need to remember 2 different main pathophysiological mechanisms of acute kidney injury in heart failure. That is, you have renal hypoperfusion, which is mainly related to arterial side of the circulation. And on the other side, we have renal venous hypervolemia and hypertension due to volume overload. So obviously, we need to be very critical in assessing this. We need to understand which is the cause of acute kidney injury in the setting of heart failure. I agree in clinical practice that is difficult, but that is quite important, because if the acute kidney injury and deterioration in renal function due to hypervolemia as a result of renal venous hypertension, as in this case, then you need to push more diuretics, even though you are going to see some more deterioration in renal function, but you need to be reassured that at the end is going to be okay, as is what exactly happened in this case. So obviously I will go with IV furosemide for a couple of 48 to 72 hours, I wouldn't mind if the renal function deteriorates a little bit, because I will know this is going to be normalized days later. Introducing spironolactone earlier on, yeah, is a little bit, maybe I am worried about that, because we know this patient is just recovering from acute kidney injury. So I will wait till discharge and see patient again and start it on MRA in this type of patient. Yeah, thank you.
Thanks very much.
Yes, yes, and could I comment?
Yes, okay, yeah.
Yes. Yes, I agree that the patient is shifting from cardiorenal syndrome type 2 to type 1 or to some worsening of his function. I agree with the policy of the dehydrating of the patient, but I will not rush to metalazone, spironolactone, and Apical, 3 of them with the diuresis, because all of them in a way or another are deleterious to the kidney. Once I am dehydrating the patient and overloading the patient, I will just stick to this one, and I will just leave the prognostic medications like Apical or spironolactone a bit later, so as not to push more harm on the kidney. I'll be just more gentle in dealing up with the patient.
Okay, thank you very much.
Yes, thank you.
Dr. Abu Saud.
Yes, Dr. Ahmed. Actually, I want to add something to what Dr. Musa said and Dr. Nasreen. As you know, one of the lessons that we learned from those trials looked at the boluses of furosemide or diuretics versus infusion. It was a negative trial, but one of the lessons we learned was that if you give boluses of furosemide, kidney function will mildly impair in the first few days, then it improves before going home, before discharge. So I agree with Dr. Musa that based on this trial, I would say I won't be very worried about some slight deterioration of the kidney function in the very early beginning of IV diuretic treatment. And I would rather, and that reflects the high renal venous pressure, which is the same like high GVP and high wedge pressure. So it's kind of a marker of high filling pressure. So I would rather carry on with IV furosemide for few days. But on the other hand, if kidney function is not significantly deteriorating, I would start giving some spironolactone or aldosterone antagonist before discharge, because kidney is not significantly impaired, and it's not acute kidney injury by definition. One more thing is this will preserve the potassium in such hypokalemic patient.
Thanks very much. And Professor Junejo, please. You're on mute at the moment, so if you can unmute your microphone.
Can you hear me now?
Yes, we can, yeah.
Sorry, I would like to second what has just been said, which is, so there is data from the emphasis and the ephesus studies of using eplerenone, and also from spironolactone, the RALS study. The RALS was in stable patient, the emphasis was in unstable patients, that there is safety. We know that the signals of renal functions are just those. They are signals of what the physiology is doing in response to treatment being given. This gentleman is not at a level where we would be terribly worried about the renal deterioration unless it was sustained. I would leave the expert comments to Saeed to if he's listening,
yes,
to clarify. But as far as I'm concerned, we would also be aiming to get. I have to say my threshold for using metolazone is probably higher than it is for spironolactone or eplerenone. I use metolazone in resistant cases when I've tried all the other bits, because we know that metolazone hits the kidneys much harder. In all of the three, so combination of candesartan, metolazone, spironolactone, I think it was metolazone that probably hit the renal function harder in this individual. I think if we had been upfront with candesartan and spironolactone, probably the renal function may not have been as impacted as it has in this situation.
Thank you very much. Dr. Saeed, if you'd like to comment.
Yeah, thank you, Dr. Junejo. What was the urine output in this gentleman? Did he record that somewhere? Was that recorded in his daily charts or not? And then the second question is, what was the indication for the metolazone? His weight was coming down.
I agree. It's a question for me.
Yes,
generally in management, whoever.
Yeah.
You would have
he was actually responding, and it was considered like a slow response. And that was a decision to give him like it's just a single dose of metolazone at that stage. You know, obviously, agree that contributed to his worsening kidney function. The spironolactone was started about 4 days prior to discharge, actually. And all these events, the spironolactone and this dose of metolazone, as we can see, and prior to that, candesartan probably contributed to the acute worsening or acute
was there
kidney injury.
looking after this patient, and they had continuity of care? Was it one team and one consultant, or was it different people looking after them? Because that's what happens when different people look after them. Everybody comes and makes a little bit of change and then disappears.
Yeah, there's some change in the, you know, the caring team, actually.
Yeah. So yeah, you
like two.
Yeah, exactly. You notice that from the medication, the way it's prescribed. Somebody's got a logical idea what they want to do, and then they leave, and then somebody else comes and they add a little bit more. Because as physicians, we always want to do something rather than wait for it to have an effect, because we're in that time pressure situation.
Thank you very much, Dr. Zaid. That's a really very, very good point. So, Dr. Hind, if you could just finish off your presentation, thank you.
Okay, so yeah, as we can see here, well, after this deterioration, his furosemide was reduced from 120 BD to 80.
If you can move on to the next slide, please. Yeah. Thanks.
Okay, but he continued to lose weight. I'm going back to just to mention about the rate control. This is his heart failure point of view. The rate control aspect, he was started on bisoprolol, which was up titrated up to 10 milligram on the 3rd day of admission. And he also was started on digoxin because his rate was not well controlled on 10 milligram bisoprolol. And that digoxin was actually increased to 187.5 microgram. So this is from the from the atrial fibrillation point of view on heart rate control. X-ray was repeated, and I just put the admission X-ray just to compare. I don't know if you can see it very well. Can you see the repeated X-ray? And as we can see, it's much there's much improvement with regard to the pulmonary congestion. So obviously, he responded very well to diuresis. On day 11, this patient was ready for discharge. He remained stable. He felt much better. His leg edema was improving. It was almost in discharge. On discharge, he was having very minimal leg edema. His urine output remained very good throughout the admission. His atrial fibrillation was controlled, and as we can see that he lost about 8 kg since admission. His creatinine was improving. It was on discharge, it was 125, and the plan for him was to be followed in the heart failure specialist nurse clinic in about 3 weeks. Those are his medication on discharge. As we can see, bisoprolol 10 milligram. He was still on the 2 milligram of candesartan. Digoxin was increased to 187.5, as I mentioned. And his furosemide on the day of discharge was reduced further to 80 milligram once a day. He was kept on a spironolactone and, of course, on his anticoagulant. So 3 weeks actually 3 weeks review happened with the heart failure specialist nurse. And during the visit, he was actually found to be stable, a New York Heart Association class 2. He reported dizziness, mainly on standing and moving head. He was still in atrial fibrillation with a controlled rate. He was hemodynamically stable. His blood pressure was fine, though the patient showed his diary of blood pressure at home, which showed a systolic blood pressure of around 100. No change was done at that stage due to dizziness. The plan was to up-titrate his candesatan, but that did not happen. And planned for a repeat transthoracic echo in 6 weeks. And he was advised to continue weight monitoring and blood pressure monitoring at home. I couldn't find any mention about the weight in the clinic visit, but this is probably due to either stable weight or no change in his weight. And I think by that I will, come to the end of this case. There are just few points for discussion, which I thought about what was the cause of decompensation of this patient. In the discharge summary, the diagnosis was just decompensated heart failure. But, if we think, and I think this was discussed earlier, is it tachycardia-induced cardiomyopathy? Is it the infection? Is it due to his tissue aortic valve stenosis, and whether this needs further assessment? Coronary artery disease possibility, but unlikely, given that he had no history of chest pain. There's a comment of no regional wall motion abnormality, but I think the echo is not really informative. It might maybe need a contrast echo to further assess his LV function. He also had 2 years ago, he had a CT aortic root, and there was no comment about significant coronary artery disease. The other point about the fluid restriction and how to balance the and reserve the renal function, we talked about that. I think it was in this case the maybe early addition of some medication contributed to that. But it's the point of fluid restriction, because I think there's some controversy and some opinion about treating those patients or considering restriction of fluids on patients with heart failure. So I think this is the last slide for this case.
Okay, thank you very much, Dr. Hind. Does anybody have any comments?
Thank you, Ahmed. Can I just say thank you very much, Dr. Hind, for bringing this practical approach to how to apply knowledge in this kind of very challenging case. And I got just a few questions from the audience. I think we're going to start with Dr. Junaid. Just a very quick comment on this case, basically. Why we don't use deuterium infusion early in this case? And the second question, what about the DC cardioversion in this kind of patient? He came with heart failure, and clearly he's in AF with rapid ventricular response. And the third thing also, is there any role in hydroxychloroquine in this kind of patient? Dr. Junaid, can you hear me?
Is this for me, yes?
Yes.
Okay, so I think, yeah, exactly. I echo the word. I think it's a fantastic case to bring in and raises a number of practical issues that we need to address. So first things first, we are not clear why this person deteriorated. We have presumed that the temperature perhaps was suggestive of some kind of infection, although the CRP was fine, and we empirically treated with antibiotics. I'm not entirely sure that we can reliably say there was an infection somewhere. The chest X-ray was abnormal, but not abnormal enough with focal consolidation. The difference between the two chest X-rays could easily be explained, in my opinion, and this is my personal opinion, on exposure alone. Is a big individual with a rotated, very underexposed chest X-ray, and then the second X-ray is better positioned and more penetrated, and you can see the difference. So I reserve my judgment on the infective side of things. ECG was clearly more abnormal than, what's different from the first one and was more abnormal. The axis deviation was present on the first one. There was left axis with narrow QRS complex. The second ECG showed broader QRS complex with almost a incomplete left bundle branch block presentation. So whether that was conductive tissue abnormality as a response to cardiac decompensation, myocardial stress, or whether there was an ischemic element, we will never know. He didn't have chest pain, he didn't have troponin, and therefore we are not sure whether this was purely a physiological stress or whether there was an ischemic element to it. It is unclear why we didn't do a repeat ECG and whether that changed along the course of the admission or not. and it is unclear why we didn't do an echo prior to discharge when his heart rate is 81 in atrial fibrillation. So I stand by my original sort of comments when we were initially discussing this case, which is, to me, if I assume that there is no ischemic element and the temperature is probably just a red herring, then the only obvious identifiable cause of cardiac decompensation is a new atrial fibrillation. And that is in the context of probably a degenerative tissue aortic valve. Now, I understand that it is difficult to be confident about the gradients and so on and so forth in rapid ventricular response atrial fibrillation, but we could have perhaps had a better idea if we repeated an echo prior to discharge. But my original plan stands. Control the rhythm as quickly as you can, or offload them, stabilize them, control the rhythm as quickly as you can. If you can do that, you're better off. As you see in this individual who was seen 3 weeks later, still in atrial fibrillation, with some element of postural change, hypotension, but we've not done anything to correct the primary the presenting or precipitating factor, in my opinion. So I think we've still left him without the definitive treatment that I think would have made a difference in his symptoms and his outcome.
Thanks so much, Professor. Dr. Abu Saeed.
Yeah, just to add something to what the Prof. Junaid said, is that the mean gradient was in 20s. I mean, through the valve, it was in 20s when ejection fraction was 45. And during this admission, the gradient is in high 30s when LV is severely impaired. So I think there is something significant going on with this aortic prosthetic valve function, and that need to be reassessed. Not, I think
absolutely agree, but we need to reassess it in sinus rhythm because the first ones were done in sinus rhythm. So if we want to bring him back to sinus rhythm and then reassess the valve to see whether the 8 or 10 years down the road of the valve implant there is need for us to do different, absolutely. I you know,
absolutely.
A very astute observation. Well done, thank you.
Thanks.
Yes, I've got to comment.
Yes, Dr. Badri.
Right. I mean, what we would like to do for TOE, transesophageal cardiac aortic valve pain, because of the patent habit, the transthoracic was not very good way. We would like to test aortic valve to know whether it has got worse. We know that, I mean, whether a recent onset or a new onset due to his heart failure, but the assessment of the aortic valve is needed. Another question about sacubitril valsartan in this case, when we're going to introduce it in this patient.
Okay, does anybody want to take that question on?
So just before the pandemic, I think the next step would have been UE. But during the pandemic and the risk of aerosol producing procedure, that should be planned very cautiously. And one more thing, I think Dr. Badri was, because there was some people on the line, I think he did mention sacubitril valsartan, didn't he?
Yes, yeah.
So Dr. Hind, she did mention that the patient has dizziness and on 2 milligram of candesartan. So I think introducing the sacubitril valsartan at this point might be challenging as well. Thank you.
And I agree in the context of outflow tract obstruction, although moderate, I mean, we could have a low flow, high gradient aortic stenosis in the context of poor ventricle and relatively low gradient. And in this context, sacubitril valsartan is not being tried and tested and is not evidence-based. So while it is a very valuable drug in appropriately selected patients, in this context, I would hold back. And that's also coming back to what Mohammed said just there in terms of TOE. If the individual has clinically stabilized and their rate is controlled and they're clinically better, we would aim to, if you wanted to do a TOE, you could repeat the COVID swab. And if the COVID swab is negative, you could still then go with a relatively, I say that, relatively lower risk TOE, rather than going blind upfront on day one when you didn't know the result. But theoretically, these things are possible.
Okay, thank you very much, Professor Junaid. Thank you very much, Dr. Hind Elzein, for your case presentation and your efforts. And thank you, Professor Junaid, for your talk. Dr. Saeed, thank you very much as well. Thank you to all our panel members. And thank you for everyone who's listening. I'd like to end the session now. I'd like to pass it over to Dr. Abdul Azim Ibrahim.
Thank you, Ahmed, and many thanks to everyone joining us this morning and this afternoon for this very fantastic talk today. Many thanks, Dr. Saeed and Dr. Junaid and Dr. Hind and Dr. Yaqub and Dr. Nasreen and Dr. Muhammad Abu Saud and Dr. Muhammad Al-Badri and Dr. Ahmed Adlan as well for taking your time to joining us and to talk to us and to share your knowledge, your experience with us during this is very difficult time. We really appreciate it.